Thank you very much, Christian, for this nice introduction. Good afternoon to all of you. So it's my privilege to talk about diagnostic algorithms, novel diagnostic algorithms in suspected ACS, acute coronary syndromes, and to talk mostly about the chances, but also the new challenges that might arise. So I have several topics to disclose. So first, this is disclosure number 1, and at the same time proof that I used to have more hair when I was younger. This picture was taken at the very first great meeting in Rome in 2009, where I had the chance to attend this meeting together with my friends from Basel. So disclosure number 2 is my research group is mainly funded by public grants from societies, from foundations, but also supported by several industrial partners to whom we'd like to thank for the most valuable support. And last but not least, also to disclose the following. I'm co-founder and shareholder of the Artemis Hamburg Limited, which is a spin-off of the UKE, which holds a patent on one of the diagnostic algorithm. And I think this is exactly one of the topics that we need to talk about today when it comes to the new chances, but also challenges of bringing new algorithms to the bedside. So let's start with acute chest pain, so the easy thing. Whenever we see a patient with chest pain presenting to the ED, we, the physicians, have 3 diagnostic cornerstones. First, we can use symptoms and clinical history of the patient. Second, we have the ECG information. And last but not least, we have troponin. Cardiac troponin, measured serial within the blood, thereby plays a very major and dominant role. And you are all familiar with the timeline. So Gesa has shown very nicely earlier the evolution of troponin, the clinical introduction in clinical practice more than 10 years ago, the introduction of the ESC 03 and 01-hour algorithm, and more detailed approaches, including machine learning approaches, including the Artemis approach and the code ACS approach from Nick Mills and his colleagues. So we'll hear more about the code ACS approach and today also about the Artemis approach. So let's talk about the ESC 01-hour algorithm just very briefly. At least in Europe, I think this is one of the most frequently used algorithms in the EDs, supported by the ESC guidelines with a class 1 recommendation, and it categorizes patients presenting with suspected non-ST elevation myocardial infarction according to troponin concentrations and changes into 3 categories: low risk, rule out; high risk, rule in; and the observe zone. Many of us were involved in the development of these 01-hour algorithms. They have a very, very high safety, so negative predictive value for myocardial infarction is very high in the rule-out group. They are efficient, so about 60% of the overall population are triaged towards rule-out after 1 hour. But still some limitations are there. For example, only about 15% of all subjects can be triaged to the low risk group, to the rule-out group, based on a single troponin measurement. So again, we are all believers and big supporters of the ESC 01-hour algorithm, so no doubt. It is very fast, it is safe, it has been extensively validated in many settings, and it is very easy to apply, at least when it comes to the application of these cutoffs. So you can just print these diagrams out, stick it to the wall, and apply them in the ED. However, there are still some limitations. So first, these are fixed SS-specific cutoffs. Then it requires fixed timing of serial sampling after 1 hour or 2 hours, which is sometimes difficult in the busy ED setting. Third, it is only based on troponin, so at least the ESC 01-hour algorithm. Apart chest pain onset time does not include any other clinical information, despite the 3 diagnostic cornerstones, which also includes patient characteristics, symptoms, and the ECG. And last but not least, it only allows to categorize patients into 3 categories, into 3 bins, but it does not allow to estimate the personalized risk prediction, so a probability between, let's say, 0 and 100% probability. So there's a need for a more comprehensive and flexible approach. And in other words, we need and we want to squeeze more out of troponin. Machine learning may be one of the solutions, how to enrich troponin with more information. And again, the ACS Pathfinder from the Artemis project and the Code ACS project are two approaches that try now to further improve how to best apply biomarkers together with clinical information to triage patients with suspected myocardial infarction in the EDs. When talking about the Artemis project, because this is where I was involved, Artemis stands for Artificial Intelligence in Myocardial Infarction Study. We aim to derive and validate a machine learning approach which estimates the individual probability of myocardial infarction. So exactly the number ranging from 0% probability up to 100% probability. We have trained the model within the Artemis network, which consists of many cohorts from 4 continents, 27,000 patient-level data harmonized in Hamburg. So it was a collaborative effort, so not a standalone project. We split the data set in a derivation, validation, and generalization data set. And in very brief, I do not want to go into details now, it allows to apply 6 different troponin tests, including 2 point-of-care tests within the Artemis approach. We offered the models more than 20 clinically available variables. 12 of them were selected by the machines. It was not only one single machine that we use 4 different machines in order to take the information from all different models to create a superlearner which provides more robust data. And these are the variables that are included. So, of course, troponin concentrations, time between serial measurement, if the serial model is applied, several cardiovascular risk factors, and the ECG. So, in brief, in the end, every patient gets a number between 0% probability up to 100% probability. In our data set, we suggest to consider patients as low-risk patients if the probability is below 0.5%, and high-risk rule in if the percentage is higher than 50% for the probability of myocardial infarction. So, whenever we apply a new algorithm, whether it's a Code ACS or the Artemis ACS Pathfinder approach, we need to compare it with the current standard of care to see what it further, to which extent and where it further improves clinical care. And again, here we see in the Artemis data set the ESC, so 1-hour algorithm's performance, which is excellent. So the negative predictive value is very, very high. The safety is excellent. But based on a single measurement, here we see the numbers for the single measurement, the proportion of patients that are eligible for direct rule out is only about 12 to 15%. When applying the Artemis ACS Pathfinder approach, again, the safety is excellent, so 99.5 or higher. However, the proportion of patients that all of a sudden, let's say, eligible for direct rule out rises up to 50%, so the number increases by factor number 3 when enriching troponin information, single troponin information with more clinical data, which is routinely available there and very easy to assess. So only ECG information is the thing you can't ask the patient, but you need to perform an ECG anyway in all of these patients. So let's start using it today. Are these machine learning algorithms ready for prime time? We would love to use them today, but unfortunately they are not yet ready to be used. But why? What are the challenges in order to enable their clinical application nowadays when using machine learning approaches in particular? So these are some of the topics I would just really briefly would like to touch on. So there's the need for calibration in different courts, in different settings, in pre-hospital setting, at GPs, for example, if you use a point-of-care test, which is key. Second, there's the need to provide access to these algorithms, so you just can't print them out and stick them to the wall. It's a digital application. Third, you need the certification as a medical device. You need strong partners to enable all of these steps. And last but not least, you also need prospective real-world data to further support these findings that we have observed and others have observed with their novel algorithms. Talking about calibration, it's no longer only a yes or no or low, intermediate, high prediction, but you predict a precise number, and you need to be sure that if you predict that you have a probability of 0.4% in Hamburg, that the same patient would have the same risk estimation also if you present it in New Zealand, in Heidelberg, or at the GP, not in the ED. And this is a topic, a methodological topic, which needs to be addressed. It seems very simple, but it needs to be proven, as here, that prediction, the calibration in the derivation, the validation groups are very, very similar. Second, how to make it digitally available. We are now developing an app and a web interface, but Gesa also talked about digital solutions, so medical decision supporting solutions. So these algorithms could be implemented also in such records. Many of the input variables are digitally available anyway, let's say troponin information, timing between serial measurement, heart rate, age, sex, and so on. So these variables, most of them are collected anyway in the electronic health or the medical record system in the clinics. Certification. This is quite an issue because every software-based medical decision support tool is considered as a medical device. And therefore, you need a certification by a notified body in order to enable the clinical application as a medical product. So, for example, in Europe, it would be the CE mark. In the US, it would be the FDA. In Canada, it would be a different regulatory body. This is challenging. This is something new. This is something we did not need for the ESC 01-hour algorithm. So this is a new challenge. Therefore, it's a long, highly regulated and costly and sometimes complicated process, and you need strong partners. And you need to be flexible, have a good constructive environment. The academia, the universities can partner these steps only at the very early phase, but sooner or later you need to push it to enable the clinical application. So, for example, with Artemis, therefore, myself and some colleagues, we founded a spin-off of the University Hospital in Hamburg and founded the Artemis Hamburg GmbH, because within this body, we now try to cover all of these steps to not end ultimately only with publications, but also to see it sooner or later being applied, not only Artemis, but also other approaches in clinical practice. Last but not least, we need to provide more data. Not only the industrial partners need to do so, but also we, the academic partners, when developing new algorithms. This has been done with the ESC 01-hour algorithm, and this needs to be done also with novel approaches to provide more real-world data. When it comes to the ACS Pathfinder from Artemis, we have the following study program. We are now preparing a clinical trial to test for the clinical performance at the GPs using point-of-care devices in the preclinical setting, German-wide in ambulances, and from a global perspective also in the EDs. Dear colleagues, I would like to conclude with the following findings. First, diagnostic algorithm in suspected acute coronary syndrome is a success story. We have seen the development, the evolution, and many of us have been involved. However, there is still the need for a more personalized and flexible approach, and machine learning techniques might be key to help enriching troponin with more data and further improving the personalized triage of patients presenting to the ED. And thereby, however, we need to be aware that new challenges will occur, that we will be faced with whenever we decide to have a digital solution available in any field, in suspected myocardial infarction, in heart failure, that we'll hear from Nick Mills later. I think it's tomorrow. But still, together, I'm sure that we can all make it to bring digital solutions also to the bedside. And therefore, thank you very much for your attention.
Thank you, Raphael, for your wonderful insights into the world of machine learning. Until perhaps the first question is ready from the floor, I would like to start with one you introduced. We were aware of derivation and validation as a necessity for algorithms. And I realized, so you had a rather, for a machine learning approach, small cohort for derivation, and a rather small one for validation, and a really large one for generalization. Can you explain to us what means generalization? Does it still impact on the algorithm itself and further improve it, or is it part of the validation?
So a very important point, and thanks for clarifying this important step. So we have labeled these three groups according as you have mentioned. So the algorithm and the feature selection and the machine selection, they were all fixed in the derivation group only. So in these 2,500 patients, so the algorithm wasn't touched anymore later on. In the derivation group, then we tested for the possibility to calibrate. and we have fixed the calibration, and then we have defined on that, and afterwards we have applied the calibration to the generalization. And in the generalization data, we had data from all over the world, not all over, but 4 continents, but the features and the weighting of the different features in the algorithm, it was only done once at the very beginning in the derivation data set.
Thank you. Alex, please.
Thank you. Thank you very much. You are giving hope to all the fellows here to be professor in Hamburg one day. Then we are going to all go to Hamburg. Congratulations for your journey. MDR, CE mark, and FDA. Can you tell the young generation who is going to be more and more involved in AI and biomarkers what is really needed for those regulators to be approved and maybe one day being used in the market?
Well, so the most honest answer would be, I would love to know myself. Because when it comes, at least to the European setting, the new medical device regulations that came in place just recently, so there's quite a substantial amount of uncertainty because the notified body approves it at the very end. So it's quite different to the US, where the FDA gives you some counseling recommendations quite at the very beginning and tells you what you need. In contrast, in Europe, so they are just very, let's say, objective, and they make their final decision at the very end of the journey, whether they say, well, all of the data that you show them at the very beginning is sufficient or not. So therefore, at least in Europe, there's this uncertainty which still exists, and there are not too many digital solutions that have been approved with the new medical device regulation yet. So unfortunately, I hope maybe next year that at least for a European perspective, and this is where we're starting with the certification, therefore I cannot comment on the FDA setting, we still have this lack in certainty.
Please.
Hi, my name is Sui Han, I'm from Singapore. I'm glad to see that you also include a population from Japan, in your study. Do you find that they fit well to your algorithm, or you need sort of fine-tuning for the Asian population? Because in Asia, the top cause of death is cancer, 1/3, and the cardiovascular is the second cause, about 20%. So maybe there is a genetic difference, and may need to fine-tune your algorithm for the population in Asia. Yeah. Thank you.
So excellent. This is exactly why we want to include a huge variety of populations, and this is data from Japan and Taiwan. And I mean, all of them present with chest pain to the ED, and this highlights the need for the recalibration or possibility to calibrate and recalibrate to completely different settings. Data started from one German derivation, was from a German study, and we show in the full publication the performance in all different cohorts. So I'm happy to share with you also how it performed in the Asian cohort, and there, after calibration, it works very nice.
Nick, please. Great that you're here. Challenge him.
Sorry, I was slightly late, everyone. Wonderful presentation, Raphael. Couldn't agree with you more on all of the challenges for next steps to deploy these tools for patient benefit. I'm interested, you mentioned randomized trials as part of your pipeline, and I guess it made me think a little bit about what is the level of evidence required to demonstrate the value of these algorithms over and above the very effective pathways that we already have today. What do you think we need to try and achieve in the next phase to convince everyone that this is the way to go?
Yeah, absolutely. So I mean, again, you are asking for randomized controlled trials, something we hardly see for any other biomarkers. So I mean, we are the demand increases to bring biomarkers into clinical practice. For some extent, it's for the good. Sometimes it's just kind of limits its clinical application. So I mean, when it comes to these studies, these will all be wedge-controlled trials. We are planning, so when it comes to study pipeline, but then you can't include 20,000 of patients that present to the GP. So the question is, which is more important? Is it efficiency or safety? So in our studies, we try to find a good balance between maintaining the safety, but increasing the efficacy, especially based on a single rule-out measurement, and the value for, let's say, in the ED, it differs from setting to setting. In the ED, it would be a huge benefit if you could rule out patients based on a single troponin measurement with the help of code ACS or with the help of Artemis immediately, without the need for serial sampling. So it speeds up and accelerates the time you need to spend in the ED. It's different, the benefit for the GPs. For the GPs, right now, they do not have really possibilities to, I mean, some of them, the ambitioned ones, they have a high sensitivity point of care assay, but right now they don't have tools to enrich it. So this would be kind of expansion with your approach and our approach. So this would be an additional, a new benefit. It's not only fine-tuning, it would open a new door, let's say. The same for the preclinical setting. The preclinical setting, again, it differs in Hamburg. I mean, there are 100 of hospitals, so the need, I mean, the next hospital is just over the road, but for more rural areas and countries, then also in the pre-hospital setting, its application might provide new and additional value than the standard kind of care.
Last question from Dr. Lopez Ayala.
Moin, moin, Raphael. So,
good morning.
Congratulations for the very nice presentation and also for the Artemis project. So my question is a little bit similar to the one of Christian. Machine learning is data hungry. Machine learning is data hungry, and recent simulation studies have shown at least 20 times more number of patients per, of events per variable. So roughly 100 to 200 events per variable for dealing with overfitting. And this would be my question. I think you said 2,500 patients for the derivation data set. So did you apply any specific maybe machine learning methods trying to solve this issue? How did you, it's excellent to have a very large external validation as you showed, and the calibration curves were more or less okay, but how did you tackle these main issues of the derivation cohort?
Yeah.
Thank you.
So, excellent point. So, maybe disclosure number 4 is I'm a physician, I'm not a statistician. So, but what we see in the end, what do we use? We use multiple imputation, we use bootstrapping to further stress the variables in the derivation set. And the simple answer is, in the end, with this huge derivation and particularly validation data set, we could show that it works very well. And I mean, I would just comment on the calibration curves. I mean, they look at least very nice, I would say. And I think this was quite a difficult task that we have set with the help of the derivation data set. At least the data speak for themselves, that it seems to work very nice. And the calibration curves, if you look at different projects, I mean, we are not unlucky with them, I would say. So we are glad to see that obviously it works. I don't know, or I know this rule of thumbs, but in the end, I don't know how to comment on that and the limitation. The simple answer would be, maybe it's not that important, this rule of thumb, if we see that it can work even in such a setting.
Thank you very much, Raphael. Thank you.
Thank you.
Thank you.